Okay. Bom dia, bom dia. Welcome everybody. I have a big public today. Very happy that you all came here. International public, yes. So welcome also everybody here online. Just to start, as always, I invite you to follow our YouTube channel. We upload many nice, good content, so please follow us and ring the bell if you like what we share. So today we have a case. Yesterday we asked you a question about what would you do with this kind of patient. We have a male patient, 32 years old, with generalized moderate teeth wear, with aesthetic complaint, but without any symptoms from TMJ. And the possible answers were, we do 6 veneers from canine to canine, we do a full mouth rehabilitation using ceramic veneers and overlays, or we do a full mouth rehabilitation using a flow injection technique. And let's see the answers. So the answers, I actually really expected that. It's mostly the answers are in between the second and the third option, and we have like quite almost 50-50 here, okay? And a smaller percentage of the less of a smaller rehabilitation. So what did we do with this patient and why? Let's take a closer look to this patient. As you can see, we have quite loss of tooth structure, flattened restoration, short crowns. Okay. And actually, nowadays, in our clinics, we get more and more these kind of cases of the patient with generalized tooth wear. What we can see is the crowns, as I said, are shorter, the restorations are flattened. In this very patient, the factors that provoke the tooth wear were combined erosion and attrition. And according to this study, nowadays we can have even 30% of erosive wear of permanent teeth in children and adolescent patients, which means this is a pathological tooth wear. This is not physiological tooth wear. So we have a loss of tooth structure not adequate for the age of the patient. And normally the etiology of this wear is multifactorial, but normally it's derived to erosion, abrasion, and attrition. In this patient, in the intraoral exam, we noticed the loss of canine guidance and anterior guidance. So functionally, he's not working good, and we can observe many old leaking infiltrated restorations. So traditionally in the past, how we were treating this kind of generalized tooth wear. Normally in the past we were using a full crown coverage and full mouth rehabilitation for these patients. But nowadays, as we have everyday better adhesive techniques, we can use a more minimally invasive approach. And based on that, we could offer to this patient 3 options of treatments. So the first option would be the full mouth rehabilitation with ceramics, which would give us the best aesthetics, the best precision, and the best stability of the shade during the treatment time. I mean, the wearing of the restorations. The second option would be full mouth rehabilitation using composite, which would be for sure more affordable, but wouldn't give us so great aesthetics and so great longevity of the restoration. And the third option of the treatment would be only stabilization, observation, and using a splint, which would decrease the harmful forces during parafunctional movements and which would stop the further wear of the teeth and TMJ problems. And here exactly we have that half-half split in between your votes, because actually the choice is not so obvious. So normally we would say that ceramics is the best option. Minimally invasive ceramics, meaning veneer, veneer lace, and onlace would be the best option for this patient. But are ceramics the only choice? So normally clinicians, when we need multiple anterior restoration or a full smile change, metamorphosis, we tend to choose indirect options. But indirect options, meaning ceramic veneers, mean cost, bigger delivery time, and could be a bit more invasive than, for example, composite with flow injection technique. So choosing here in between ceramic and composite, which are actually our concerns. Talking about patient with tooth wear, so we already lost, normally in severe or moderate cases, we already lost like 20–30% of tooth structure. So do we want to cut them more for ceramic restorations? We are concerned about further tissue reduction, so this would be our doubt. And also, especially for the patient, the doubt here would be a bigger cost. And then talking about composites, we have the doubt about the longevity of the treatment, of the restoration, and also the aesthetic and functional outcome. Will it be stable enough in terms of shade, in terms of chipping appearance? So let's analyze a bit, checking the studies we have available. There is actually not so many available literature about the usage of composite in severe tooth wear. We have a study that tells us that in tooth wear, the restoration, look, the 30 months, okay, sorry. So the composites used in 30 months has quite a big percentage of success, which is 89.4%. But after 10 years, the success dramatically drops to 62% in the usage of composites in the tooth wear, comparing, for example, with metalloceramic crowns as 74.5%. And then let's compare with lithium disilicate crowns that in 10 years, we have a percentage of 85.5% of success. So we have actually a way bigger success than for the composites. Now, when we talk about composites in this kind of cases, we want to do flow injection. And now you will say, okay, but flowable composite, is it strong enough? Is it resistant enough to use in this kind of attrition cases? So in the beginning, when they only invented flowable composites, in the beginning they didn't have so good mechanical properties. They only had 37–53% of the filler, which was influencing a lot the properties in terms of wear resistance, strength, polishability and translucency. But nowadays, with contemporary flowable composites and with nanotechnology, it was increased. So we have 62–69% of the filler, which is compared with normal paste composites. So the properties of flows are really comparable with normal paste composites. So in this method that would be recommended here in injection flow technique, also what helped us to improve the invention of polyvinyl siloxane, so clear silicone molds. So finally we could actually copy the digital wax-up, the wax-up of the patient, and introduce it in the smile of the patient with the usage of injectable and polyvinyl siloxane. So based on this study, as I told you, there is no significant difference in properties in between flowable and conventional composites. And what this technique gives us, flow injection. The flow injection is good because it's fast and it gives us a very conservative approach. It helps us to plan and manage good decays, and we can, as I told you, copy exactly the planned OVD and the planned reconstruction of the smile and paste it somehow to the teeth. And we can use it in light, moderate, and severe wear. But in the end of the day, as we have this choice in between ceramic and the composite, the choice is up to the patient. So we have to explain to the patient the advantages and disadvantages of both of the methods. And in this very case, the patient, our recommendation actually, in this case, would be ceramic. So like 50%, 40% of you voted ceramic. But because of the high cost of the treatment, the patient chose the second option, which was composite injection. So we proceed with aesthetic and functional evaluation, and we produce the digital wax-up. And then, based on the digital wax-up, we produce the mock-up in the mouth of the patient. While the mock-up is in the mouth of the patient, we have to really check thoroughly the points that you see here. Why? Because in these kind of cases, as the composite is a second choice, we have to really plan good and we have to really evaluate good the function, for we don't have any consequence in the future with chippings and with chippings and problems that could appear. So what we evaluate with the mock-up in the mouth is lateral extrusion, protrusion, maximum intercuspation. We check also aesthetically the teeth shapes, lengths, and the thickness of the veneer. Why? The thickness of the veneer also because we don't prepare the tissue here, so we don't make any space. So already based on the mock-up, we can see which places could be problematic in the future because of the very thin layer of the composite, and this could be an aesthetic issue. Okay, so as we talked, we continued with the treatment. The teeth were prepared accordingly. The prismatic layer of the enamel was taken off by polishing. The teeth were etched accordingly, and the clear silicone mold was placed on the teeth, and through the access holes, the flowable composite was applied. And here we have a final outcome. So after the silicone mold is taken off, we of course finish, we polish, and here we have the outcome after 1 month follow-up. So we can see that with this minimally invasive direct approach, we can give quite a nice aesthetic effect. This is not the same as the ceramic, so we have some kind of compromise. As I told you, a bit problematic zones can be the zones where we don't have any preparation of the tooth, so the very thick layer of the composite can provoke the transparency, or too big transparency here, and we can have a bit darker color than we would like to have. Nevertheless, the function is given back to the patient, so we rehabilitate aesthetics, we rehabilitate function, so still it's a good option. I don't know if you can see good on this photo, but also here we can see that it can be a bit compromising, the usage of this technique, because we don't have a full coverage and we have a bit of difference of color in the added edge. Still, it's a good compromise. Still, for many patients, it can be a first choice if we only remember about informing the patient about all the disadvantages of this method. So patient has to be fully informed, and the patient has to know that this is some kind of semi-permanent restoration. This will not last forever, and the patient has to consent 2, obligatory maintenance of this restoration. The patient also, we can actually classify him for this kind of technique, should have perfect oral hygiene and should obligatory use the Michigan occlusal splint for sleeping after the restorations are done. And as I said, the longevity of the restorations can be compromised, so patient has to be informed about this. So this is how we resolve this case. I hope you liked it. I hope also maybe a few words, about why the first answer wouldn't work here. Because actually both of these answers could be good in this case. For this answer, it cannot be good because we have a generalized tooth wear and we have a loss of vertical dimension. So we cannot only restore 6 front teeth because it will not function good. It will chip and it will not restore functionally this patient. So once again, thanks so much. Thanks for voting. I hope you liked it. If you like us, once again, please subscribe and follow us and join us next week for the next session of What Would You Do? Thank you.